Hello, my name's Joe Savon. I'm the medical director of New Life Medical Addiction Services in Marlton, New Jersey. Thank you for taking the time to look at the videos on our site. We appreciate that. Today I'm going to talk about opioid issues, which certainly are a very pervasive problem in this country and causing a lot of hardship, sorrow, and deaths. And we really want to try to explore where it came from and also to talk about what we can do about it. Where it came from, I mean, heroin was imported into this country, it really started with the French Connection, which people may remember, but that was in the 60s. But it was an underclass type of a product initially. It's really not anymore. It's a middle class and upper middle class problem. But so heroin is part of the problem, but people, for opioids such as oxycodone, hydrocodone, OxyContin, these things were overprescribed. There's a role for them in pain management. It's very difficult to get by without it if somebody's had major surgery or has pain issues. However, in the pain management field right now, you're really looking at non-narcotic treatment modalities like injections or non-steroidal anti-inflammatory treatments like ibuprofen. They tend to work just as well for pain with far less side effects. But what happens in a lot of medical offices is that people don't want to, doctors maybe don't want to or maybe don't have the time to talk about the issues or to get to the bottom of what the patient is really asking for. So too often in a 5-minute interaction, the patient leaves with a pill. And what that pill does, a lot of patients are happy because they feel that they got something of value from that interaction, but the doctor moves on to the next patient. But what is occurring is that there are people getting narcotics long term that really, if there were a comprehensive treatment program available, they may not even have been started on them in the first place. Now, once you have those pills, there's a good deal of diversion. So you will see family members taking the products and then either selling them on the street or using them. However, when you look at the prescription products, they're very expensive. So people are going to run out of money pretty quickly. Heroin's not expensive. But the problem is not only using an intravenous product and leaving open the likelihood of hepatitis C, HIV, or other infectious modalities, but it's also it's more consuming on your life to take a product like that rather than a pill. Now, not only is heroin out there as a problem, but the heroin is laced with fentanyl. Fentanyl is a very long-acting narcotic which is much more powerful than heroin itself. It's cheaper to make fentanyl than it is to grow poppies. And so as a result, now we have a much more powerful product that people may not be ready for. There's also carfentanil. Carfentanil is an elephant tranquilizer. You don't want to be in the same room with carfentanil. The other thing is people take a certain level of comfort knowing that they have Narcan, which is a reversal agent. Okay, well, I can do what I want because I have my Narcan. Okay, well, if you give yourself the injection of Narcan or someone who is in the vicinity does so, you might wake up and feel okay, but with fentanyl, you might soon thereafter go down again. So it's problematic from the strength of the product and also the long-acting nature, which you may underestimate. So heroin out there is a big problem. If you use heroin once, you have a 23% chance of having a substance use disorder involving heroin. That's tough. I mean, you could grow up in the best situation, have the best family, go to a nice school, and I'll tell you what, you have a bad day. That's what it could take for your child to become addicted to heroin. A bad day when somebody just says, why don't you try this? And you say, yeah, why not? it can't hurt. I'll just do it once and see what happens. Now, once we have this situation, the entire day of a heroin addict can be devoted to getting the product and getting the money to buy the product. So now all social interactions may be gone. Family members are disregarded. And so the entire day is involved with making sure that you can get your next fix, because if you do not, it's a very uncomfortable withdrawal process. Now, traditionally, the treatment of opioids has involved counseling and destination rehabs. Personally, I do not think that going to Malibu is the appropriate way to treat somebody with an opioid addiction. It's not a vacation. It's a medical problem with disrupted neurocircuitry that is going to be disrupted for at least a year. Counseling, what do you think the results are? You know, because you're paying a lot of money for this. You're paying $1,000 a day a lot of the time for this counseling. 30 days, 30 grand, $30,000, that's real money to me. I would imagine it is to you. 90 days, $90,000, and I think you're sending a false message and telling somebody to go to Florida, and it's beautiful. It's really, really a nice place. Well, I'm sure there's a role for everything, because I don't like to go negative. I just base my thought process on the facts and see where we can do better. But I think for the most part, people are being failed. They run out of money. Parents are mortgaging their homes. And after 1 year, the recidivism rate with heroin is 85%. So only 15% are going to be heroin free if you get to 1 year with counseling alone. In Harvard online course, it was just recent, I just recently viewed it, they said that counseling alone is really an irresponsible route to take with a patient who is physically addicted to opioids. They should be offered medications, because of the fact that if you offer medical assisted therapy, that 15% success rate goes up to 40%. And in a lot of studies, putting counseling on top of medical assisted therapy, you're still at 40%. Now, we do not advocate lack of counseling. We think counseling is very important. And so that's really part of our program. But what is medical assisted therapy? Because medical assisted therapy isn't just to tell people to quit, just talk it out. That can be really hard to do, and maybe at some point after a year, after 2 years, maybe talking it out is perfectly acceptable. However, medical assisted therapy provides a bridge, and sometimes that bridge is long term, and the bridge may not end. But methadone has been, the one that has been used for the longest, and methadone is only available in a clinic. Methadone therapy is something that personally, if I had my child on methadone versus the risk of going out and consuming heroin and what's on the street, I would definitely pick methadone. Methadone, however, is a tricky drug, and a methadone clinic should be well aware of how to use it, but it's not an easy drug to manage, because despite the small amount of methadone use in this country, it accounts for a disproportionate number of deaths. And the reason why, it's very long acting, and your analgesic effects, so if you're using it for pain, which sometimes it is, and it can be used for pain in this country, your analgesic effects are much shorter than your respiratory suppression. So you are respiratory suppressed for a long period of time. If you use additional narcotics like heroin in that window, you have a very significant risk of dying. There's other things that are interesting to me, is that from a cardiac perspective, there's something called a QT interval. QT interval is, some people have that congenitally, and if you use methadone in the setting of a QT interval, it can cause a very dangerous cardiac arrhythmia. Finally, the thing that personally I think is fascinating when you're comparing methadone to Suboxone, which I'm going to go into next. Methadone raises prolactin levels, and prolactin levels in the brain lead to, among other things, impotency and lack of sex drive. Now, that's important because of the fact that we want people to establish relationships, an adult relationship like normal people do, or going, that's an important concept, that you move away from being the addiction patient to being the normal individual functioning in life. So that's something that is underappreciated, but should be considered, because some people want methadone over Suboxone, and I think that should be part of the armamentarium. What's more often used right now is Suboxone, which is buprenorphine, and also naltrexone. Buprenorphine is a partial agonist at the mu receptor, the mu opioid receptor, and it is an antagonist at the kappa receptor. The antagonist at the kappa receptor may make people feel better in a way because their mood might be elevated, but the partial agonist effect is different than methadone, which is a full-on agonist. If heroin gets you here, where's methadone going to get? Here. Where's buprenorphine going to get? Only up to here. It's not going up to there. And it avidly binds receptors, so if it's really blocking those receptors if something else is used. The only caveat is if people are using Valium type medications, benzodiazepines, or drinking a lot of alcohol, you can get to a point where it actually mimics a full-on agonist. So you have to counsel people against using other medications. But the partial agonist, what's the purpose here? The purpose is to get rid of the cravings, because that's what people are really trying to do. You want to get the cravings under control. I had a patient who came to me and said that she was so scared because they were telling her that she has to get off the Suboxone, and I said, well, why? They said, well, you can only use it for a certain amount of time. And you really don't. It's an individualized process, and you don't have to get off of it at a certain set point. So what I said to her is, if you're feeling okay, she's out, she has a job, she's working, everything is going her way. She's scared that if she goes off of it, she's going to shoot heroin and die because it's going to have fentanyl in it. So, why don't you just come back in 6 months? I mean, well, counseling should be part of the process, but let's revisit that in 6 months. Just stay on the product for another 6 months. That's okay. There's nothing wrong with that. No stigma attached to it. I have high blood pressure. I'm on a medication. If I go off the medication, then my blood pressure is going up. We're not trying to push medications on people, but we are really realizing that people have a very serious life-threatening problem, and counseling alone isn't working too well. So let's just think about that in the context of that's an option for people, a decent option, and I think it should not be ignored or stigmatized. You're not still a drug-addicted patient. You have a treatment for a substance use disorder, and that's what we're offering. The other thing is Vivitrol, and Vivitrol is long-acting depot naltrexone. Naltrexone is an antagonist, so it blocks the effects of opioids. You have to make sure that people you don't want to give it abruptly, because you're going to induce a very violent withdrawal. So generally, we would like people to be off any narcotic product for at least 7 days, and then you give the Vivitrol. Now, there are studies that Vivitrol and Suboxone, now remember, Vivitrol, we're not giving an opioid, but Vivitrol and Suboxone may be somewhat similar in results. One study, a VA study, found the numbers to be equivalent several months out. The only caveat is that they included tramadol as a non-narcotic, and that's questionable. That tramadol should be included as a non-narcotic. With Vivitrol, you just want to make sure in that window period. You might see somebody today, 2 days from now. I can't give you the Vivitrol, but on the other hand, in that very weakened window period, people tend to go back and start using medications. So what I'm trying to say is that, again, at New Life Medical, we want you to have access to medical options. I'm a doctor. I want to treat you with everything that I possibly can treat you with. I want you to be part of the process. And I want to be able to talk to you. I want to be able to talk to your family about, what do you think? Because what you think is very important to what I'm going to come up with. I don't give you doctor's orders. I simply make recommendations, but you're part of the process. But there are medical treatment options that are very good, and they do increase the success rate. The goal is not to put you on another drug and leave you there for the rest of your life. The goal is to also include counseling, try to make sure that all bases are covered, and we try to get you back to a normal life where hopefully that you're out in the community like you used to be, having the benefit of a quality life like you used to have. And thank you for listening to me. I appreciate it.